Welcome back to the next part and the last part of the reproductive system chapter narrations. So the topic with this narration is the female reproductive system. As you'll see towards the end, we begin to make the bridges over to the development chapter. Overall, if you look at especially this image here, this is very similar how our pelvic models look in the lab. We start here with the gross and microscopic anatomy, and then we'll go into a lot deeper into the physiology of the female reproductive cycle. So in general, the female reproductive system is also in the business of maintaining the species, and not only it is making a reproductive cell, the oocyte, but it has duct-like structures to move that oocyte, and it has a very special place, the uterus, where embryonic and fetal development will find a very nurturing place. In the lab, we said nothing about mammary glands. We'll have a very brief mention of that as part of the reproductive system. This is the gonad, the ovary. This is how we started out our exploration in the lab as well. And in general, there is the epithelium that covers this. This is a simple cuboidal epithelium, the germinal epithelium, and it's important to mention here, and we've done this with the male reproductive system as well. There are many major killer cancers originate from the reproductive system organs. So ovarian cancers, 98% of them start from this relatively insignificant looking layer, the germinal epithelium. If we go deeper, we see a set of structures that, if you have looked at the lab material, this will look very familiar. Oocyte development, follicle development, and many other events happens here in the cortex of the ovary. And when you look in the center, this is the medulla. This is where most of the blood vessels, lymphatics would be coming into the ovary itself. From the reproductive system point of view, development of the oocyte and its support is very important, and it happens in the ovary. If you reflect back to the male reproductive system, spermatogenesis is supported by those Sertoli cells in the seminiferous tubules. So the development of oocyte also needs support, and that support is given by this balloon-like structure called a follicle. While the oocyte does not change shape or size through this set of oogenesis process, even through ovulation, the oocyte remains the same size. The follicles, the supporting structures, undergo tremendous changes that continue even after ovulation. What the follicles do is tremendously supportive of the overall function of the female reproductive system. And here we're just going to name these individual structures. The primordial follicles are at the very beginning of the development. Primary follicles represent much larger follicle size. Secondary follicles represent a stage where liquid is filling a good part of the follicle, and the expansion of the liquid leads to the Graafian follicle. This is not labeled here. So this is the Graafian follicle, and it's the Graafian follicle that will burst open burst through the wall of the ovary to release the oocyte to the surface of the ovary, and so this is the process of ovulation. The remnant of the Graafian follicle will change into a structure called corpus luteum, and in about 10-12 days the corpus luteum dies and turns into this inactive scar connective tissue, corpus albicans. What you see here going on in the cortex of the ovary represents the 28-day female reproductive cycle stages. Day 14 is where ovulation happens, and it's day 15 through 28 where these events occur. We're going to have a lot deeper exploration of the female reproductive cycle, and these stages will come to life a lot more together with hormonal regulation and some clinical relevance. And speaking of clinical relevance, ovaries have a number of disorders. Ovarian cysts are bubbles formed under the ovarian epithelium. These cysts usually don't prevent any events in the cortex, so unless the cysts are incredibly large, they are not treated, they're left in place, and so ovarian cysts are nothing else but a blister on the germinal epithelium, the ovarian epithelium. A little bit later on, I'll mention another disorder which is called polycystic ovarian syndrome. Sometimes it's abbreviated as PCOS. That is a tremendously different clinical picture. That disorder will interfere with the events in the cortex, and ovarian cyst again is simply a blister, and a lot of the times this has no consequence on the working of the ovary and therefore of the reproductive system. We have looked at stages of spermatogenesis in the male reproductive system. The parallel process in the female reproductive system is oogenesis, the creation of oocyte. And we start with oogonium, which has 46 chromosomes, and through the process of meiosis we will reach the secondary oocyte stage. Please don't memorize all this text and meiosis 1 and 2. It is important to know that the very special cell division type is meiosis, and it starts with the oogonium, goes through the primary oocyte stage. The secondary oocyte is that leaves the ovary during ovulation. The unique aspect of oocyte development is that the last stage of meiosis is completed only when fertilization occurs. We'll come back to that in chapter 29. Once the oocyte is released to the surface of the ovary, we have to take the oocyte to the uterus, and so all the way from the ovary, which you see right here, we need to have a set of duct-like structures that move the oocyte along, and the starter of this duct-like structures is the fimbriae. Through the movement of the cilia on the surface of the fimbriae, oocyte will be moved into the uterine tube or fallopian tube. This is the area of the fallopian tube where fertilization occurs, and so whether it's an unfertilized oocyte that will end up in the uterus or the zygote and the early developing embryo, there's a constant movement from the beginning of the uterine tube all the way to the end into the uterus. So the uterine tube, fallopian tube, is tremendously important in moving oocyte or the fertilized embryo into the uterus. The way a uterine tube performs that movement is with the help of the cilia. You see this false-colored electron microscopic view. So this is the inside of the fallopian tube, and these are the cilia that with their coordinated beating move the oocyte or the fertilized zygote, the embryo, along. We also have a smooth muscle layer in the muscularis of the uterine tube, and guess what? Here's this word again. Peristalsis helps movement of the oocyte. This is very, very similar to what you've seen in the epididymis on the male reproductive system, where cilia and peristaltic movement moved the sperm through the tubes of epididymis. So here in the uterine tube, duct-like structure in the female reproductive system, and cilia and peristalsis moving the oocyte or the zygote or fertilized egg into the uterus. Anatomically speaking, while the uterus has many parts, all of those are serving the major function is to support the development of the embryo, which will have to sink into the uterine surface, development of fetus, and also labor and delivery falls as a functions to the entire uterus. We'll say a few special words about the cervix, because this is a bottleneck, and secretions here can make a difference in terms of reproductive function. So let's take a look at the histology, the tissues of the uterus. This is an important look. Here you see the deepest layer, myometrium, and below this slide, if you would go deeper, would be the outer layers of the uterus. If we approach the lumen of the uterus, on top of the myometrium, there's this epithelial and connective tissue mixture. So the epithelium that you see right on top of the uterine surface facing the lumen, so simple columnar epithelium lines the lumen of the uterus. What you see here is a mixture of connective tissue and glands. So the endometrium has two layers. There's a stratum basalis. This is a layer that always remains in contact with the myometrium. And there's stratum functionalis that grows during the first 20 days or so of the female reproductive cycle. And during menstruation, this is the layer, the stratum functionalis, that is shed and eliminated from the body. The stratum functionalis is the ideal place for embryonic development. So with every reproductive cycle, the stratum functionalis is rebuilt, reconstructed, and if there's no fertilization, there's no embryo waiting to implant into this, then the stratum functionalis will be removed and a new reproductive cycle will start. In terms of function, we have to mention here myometrium is important for the labor and delivery. Myometrium is smooth muscle, and smooth muscle contraction is responsible for the delivery of the fully developed fetus. We took a look at structures that keep the female reproductive organs in place in the pelvic cavity, and those are called ligaments. So the ovary itself, the ovary is this light-colored oval here the ovary itself has a ligament, and this little stalk-like structure is the ovarian ligament. You see the fimbriae here, the uterine tube. And then you see yet another rope-like structure here. This is the round ligament. This is now anchors and secures the uterus in place anteriorly. And here is what you see, the opening of the inguinal canal. Inguinal canal is totally plugged up by the round ligament. This is where the uterus is anchored anteriorly. We also mentioned in lab the broad ligament. Here you can see this curtain-like, wide, thin structure, and the broad ligament anchors the uterus laterally to the side of the pelvic cavity. Let's say a few extra words about the cervix, mostly because the cervical secretions can be helpful or obstructive to movement of sperm. So from the vagina, sperm needs to move into the uterus and uterine tube to achieve fertilization, while cervix is a bottleneck that sperm must be moving through. So the secretions of the cervix that fill the lumen of the cervix can be very thin, meaning water-like. Sperm can move through this material, swim through it at great ease. But under the hormonal instruction progesterone, a much thicker cervical mucus forms, and sperm cannot swim through this thick mucus. The thick mucus is as thick as, in terms of viscosity, as honey. The appearance of this mucus is whitish, and this forms again under the command of the hormone progesterone. We'll see that the second half of the female reproductive cycle is coming with high progesterone secretion, and throughout the entire pregnancy a cervical plug forms that prevents sperm movement to the uterus and the uterine tube. This formation of thick mucus plug is exploited by progesterone-based contraceptive pills. We'll say more about the effect of progesterone in contraception when we talk about the female reproductive cycle. Vagina is the place of sperm deposition, and maybe the most important aspect here is the normal acidic pH. This is brought about by a particular set of bacteria colonizing the vagina. Vaginal tissue makes glycogen, and if you think back about chapter 25, we have seen how glycogen can be broken down to glucose, and bacteria digest glucose into lactic acid. So lactic acid that we saw in chapter 25 form from glucose degradation is the reason for the acidic pH. So here's a few words about mammary glands. We didn't see these organs in the lab. So let's take a look at the image, and it's a lot easier to explain just why this is the mammary glands are classified as modified sweat glands. So let's take a look at this parasagittal section that shows the mammary glands, including the entire breast. So take a look at this segment. Here is the thoracic cavity, the wall. You can see the ribs and the intercostal muscles there. Then you see the pectoralis major muscle right on top of that. And then if you look up here, or if you look down here, all you see is skin with hypodermis, which is filled with adipose tissue. So what happens during breast development, this hypodermis expands, adipose tissue expands, and the mammary gland can grow into that hypodermis. If you think back about sweat glands in the integumentary system, many of those acrine sweat glands reached into the hypodermis, and so this is the reason why mammary glands are considered a modified sweat gland, because it is still connected to the skin, and the gland itself grows into the hypodermis. So the milk production is coming from lobules. We have mentioned prolactin and oxytocin stimulating milk production or milk ejection from the mammary gland. And this is where the reproductive function comes in. If you think about reproductive function as maintaining the species, providing nourishment for the newborn from these lobules fits very much into that overriding function of the reproductive system. I want to mention two clinical contexts here. One is breast cancer. When you say the word breast cancer, it would imply that this entire structure here gives rise to cancer cells. Most breast cancers originate from this very, very tiny segment of the mammary gland, the ducts. Most breast cancers are called ductal carcinomas. Connective tissue portion of the breast very, very rarely contributes to breast cancer. So breast cancer is the cancer of the mammary glands and the ducts most frequently. So this is one aspect. When you go and have a mammogram done, mammogram is nothing else but an X-ray of the mammary gland, and the ducts sometimes accumulate calcium, and those small white spots on a mammogram indicates calcium accumulation, and that is a warning sign because cancerous changes might be occurring at that location. So this is how an X-ray based mammogram can identify early cancerous changes in the mammary gland. The other clinical context is breast implantation. So breast implants can leak. The coating material can cause disorders of the breast and sometimes systemic disorders. Breast implants are very easy to insert because all the plastic surgeon needs to do is cut the skin area right here. And the breast implant itself is slipped between the hypodermis and the pectoralis major. So this is the space that easily accepts this breast implant. So we have looked at gross and microscopic anatomy of various female reproductive system organs. The rest of this lecture will be focusing on the female reproductive cycle. This is an enormous accomplishment of hormonal regulation. Several steps are required to prepare the uterus to be ready for the implantation of a newly fertilized egg and the developing embryo. But as you'll see in the image, hypothalamus is a starting place. And so let's take a look at the individual parts of this female reproductive cycle. What you'll see on these images is terms that describe individual parts of the cycle. You'll see terms that describe what's happening in the ovary, and you'll see terms that describe what's happening in the uterus in a parallel fashion. So I'll be coming back to this image a number of times, but here is where the parallel events are shown. This is probably the best image to go to, and towards the end, this is what I'll be using to look at effect of estrogen-based contraception and also polycystic ovary syndrome. But let's start at the beginning. So just like with the male reproductive system, it's the gonadotropin releasing hormone from the hypothalamus that will stimulate the anterior pituitary. This is the start of puberty, and every start of the reproductive cycle originates from the hypothalamus. GnR age release must start this entire set of events. And then the anterior pituitary responds by secreting FSH at large amounts first, and small amounts of LH, and then LH production will ramp up later on. So what can FSH possibly do in the female reproductive system? Well, it will go to the follicles, and true to its name, follicle stimulating hormone in the follicular phase of the ovary will stimulate the growth of follicles. No wonder this is called follicular phase. First, a dozen or two primordial follicles are stimulated. They grow into primary follicles, and only usually one secondary follicle keeps on growing all the way to the stage of Graafian follicle. The size of the Graafian follicle can fill out 10% of the volume of the ovary, so we're talking about a huge structure here. And again, follicular phase from the ovary is dominated by follicle development, mostly under the direction of FSH, and in later stages, luteinizing hormone LH will contribute more and more. In this follicular phase, the stimulated follicles will release more and more estrogens. This is the source of estrogen, so this is why the ovary is an endocrine organ. If you look back in the endocrine chapter, if you started reviewing for the comprehensive final, you'll see that we mentioned ovary as a source of estrogen and progesterone. Well, in the follicular phase, it's mostly estrogen. What good does estrogen do? We'll have a systemic look at this, but locally in the female reproductive system, estrogen will stimulate the stratum basalis layer of the uterus to grow and build a much thicker layer of endometrium. This layer is the stratum functionalis, and you can see how it grows all the way through the entire follicular phase of the ovary. So for the uterus, this is called a proliferative phase. Large amount of cell division results in a thickening of the endometrium, building of the stratum functionalis. I circle these phases because these are the phases of the female reproductive cycle. Again, the ovarian cycle names are here, and the uterine cycle names are mentioned separately. So let's take a look at what's happening at the end of the follicular phase when ovulation will be coming up. Ovulation will be driven by two hormonal changes. At first is an increased production of estrogen. Here you see follicle stimulating hormone stimulating the growth of the follicles, and those growing follicles will start producing larger and larger amount of estrogens. And under the stimulating effect of estrogen, anterior pituitary will be releasing more and more luteinizing hormone, and here you see a huge surge in luteinizing hormone amount just before ovulation, which falls around day 14 on the female reproductive cycle. This increased amount of estrogen, besides having an effect on the uterus, it has a global effect. Almost all cells have estrogen receptors, and so secondary sexual development excuse me, will happen, whether it's development of breast or changes in the vagina. We have increased protein synthesis, growth spurts, adding to the skeletal system happens under the influence of estrogen. Estrogen has a protective effect on the cardiovascular system by lowering blood cholesterol levels. And we'll come back to this regulatory effect of estrogen on the hypothalamus. This is going to be the basis of modern estrogen-based contraception. So this is the text version of what I just described. Early, we have development of primordial follicles, and in the uterus there was the menstruation. I'll come back to this a little later. In the pre-ovulatory phase of the overall reproductive cycle, and this is what actually I was explaining, the development of follicle under the stimulation of follicle stimulating hormone, and increasing estrogen levels causing luteinizing hormone increase, and building of the stratum functionalis in the uterus. This is how ovulation comes about. And here you see the effect of estrogens stimulating hypothalamus and the anterior pituitary. The consequence of increased estrogen levels is that luteinizing hormone levels rise, and luteinizing hormones produce a tremendous growth in the size of the follicle, and this growth continues until the follicle ruptures and breaks through the wall of the ovary. Once this happens, estrogen production drops dramatically, and so the stimulation of hypothalamus and anterior pituitary decreases. LH production drops off, but until then we have a positive feedback. Increased estrogen levels stimulate LH release. LH stimulates the growth of the follicle and the production of even more estrogen, and this cycle will go on until the follicle grows to the size that it bursts through the ovary, ejecting the oocyte with some cells, and this is the event of ovulation. So right after the ovulation, in the cortex of the ovary, further changes occur. We'll take a look at corpus rubrum, as we called it in the lab, and corpus luteum. So back to the scheme. Here is our LH-induced ovulation. The estrogen production and starting progesterone production will have effect on the uterus as well. So in the cortex of the ovary, first corpus rubrum forms, and then corpus luteum. Corpus luteum keeps secreting some estrogen, but it secretes tremendous amounts of progesterone. This is the dominating hormone, and progesterone will stimulate further growth of the stratum functionalis. Secretory phase means that in these endometrial glands, these deep crevices, glycogen will be secreted. Glycogen is a major food source, energy source for the developing embryo. So if an embryo comes and sinks into the endometrium in the secretory phase, the embryo will find the most perfect place. There will be glycogen granules in the endometrial glands. Look at all these blood vessels bringing oxygen and taking away waste products. So the embryo finds the best situation in the secretory phase. I do want to say a few words here about the menstrual phase because if there's no fertilization, the corpus luteum's life comes to an end after about 10-12 days. And when corpus luteum dies, all these hormone productions go away, and the stimulation that maintained all these secretory phase structures will go away. What happens when progesterone levels and estrogen levels drop, these arteries contract, cut off blood flow to the stratum functionalis, and the cells start dying here, and the stratum functionalis layer detaches from the stratum basalis, and the stratum functionalis layer with some blood will be eliminated from the body through menstruation. So in this post-ovulatory reproductive cycle phase, in the ovary we have the luteal phase because of the presence of corpus luteum, and in the uterus we have the secretory phase. Again, endometrial glands will secrete glycogen, creating the best location for implantation of the embryo, best support for that developing embryo. So here is our first outcome. If fertilization doesn't occur, then the corpus luteum dies, it shrivels, and it turns into corpus albicans, and as progesterone and estrogen levels drop, menstruation will start for the reason I explained on this previous reproductive cycle image. So there are many stimulatory and inhibitory effects on this hormonal stimulation to the reproductive cycle. So we have seen that low levels of estrogen and high level of estrogen are part of this cycle. Both of those stimulate and moves the cycle along. What there is an observation is that moderate levels of estrogen will cause an inhibition of the hypothalamus and the anterior pituitary. So during normal reproductive cycle, the growth of the follicle overcomes this moderate level of estrogen levels and keep on growing because it has all the momentum. But the discovery of this inhibitory effect is the basis of modern estrogen-based, pill-based contraception. So let's say a few words about the contraceptions. Progesterone-based contraceptives we've seen thickens the cervical mucus, and progesterone also has an inhibitory effect on the hypothalamus and anterior pituitary. So progesterone will prevent FSH release. So progesterone-based contraceptives act on the cervix and on the hypothalamus and the anterior pituitary, preventing the start of a new follicular phase in the ovary. Estrogen-based contraceptives exploit the inhibitory effect, and so if somebody is taking estrogen-based contraceptives, the ovary is blocked through the follicular phase, and the ovary is not allowed to complete the maturation of the secondary follicle into a Graafian follicle. So right here is the blocking effect of estrogen-based contraceptives. When you block the follicular phase, there's no Graafian follicle, and therefore there can be no ovulation. So fertilization is prevented by estrogen-based contraceptives. And then this is the best place to mention polycystic ovary syndrome. Polycystic ovary syndrome is the consequence of increased testosterone production in females. So testosterone blocks the follicular phase just about this stage. Secondary follicles may be developing, and sometime in a very irregular fashion, Graafian follicle forms, menstruation and ovulation becomes very irregular because of this blocking effect of testosterone. And so polycystic ovary syndrome is a frequent cause of female infertility because the ovulation becomes unpredictable, and so planned pregnancies are very, very difficult to achieve because of that. So the last event that we discuss here, and we will go into greater details in chapter 29, what happens when fertilization happens. So imagine in a uterine tube, a sperm united with an oocyte, a zygote, a new 46 chromosome containing cell formed. This is a new biological entity, new set of genetics, and this is the beginning of embryonic development. So this developing embryo that starts dividing secretes a hormone, HCG. This much we mentioned in the lab as well. HCG will stimulate the corpus luteum and prevents it from dying after day 10 or 13 in the luteal phase of the ovary. So corpus luteum, staying alive, will produce progesterone. This is the most important hormone for pregnancy maintenance. And so during the first trimester of the pregnancy, corpus luteum will be stimulated by the embryo itself, the embryo that is making human choreogonadotropic hormone. We will detail the role of the placenta, although in the lab we explored that a little bit as well. So embryonic and fetal development, fertilization will be coming our way in chapter 29.